All right, now we turn our attention to EKG intervals. These are going to be absolutely critical for identifying arrhythmias. Um, the PR interval, for example, is the beginning of the P wave to the beginning of the QRS complex. So this includes atrial depolarization and also that AV nodal delay. So if someone has an AV node block, that would influence the duration of the PR interval and usually tend to make it longer. So I'd like you to associate the PR interval with AV node function. So the normal PR interval is 0.12 to 0.2 seconds. So again, PR interval is 0.12 to 0.2 seconds, and you should commit that number to memory, those numbers to memory. So if the PR interval is longer than 0.2 seconds, that would be suggestive of an AV node block. Now, if the PR interval is shorter than 0.12 seconds, one of the more common causes of that is if there's an accessory pathway that allows early excitation of the ventricles bypassing the AV node. This happens in some conditions like Wolff-Parkinson-White syndrome and other pre-excitation syndromes like that. The QRS interval is the beginning of the QRS to the end of the QRS complex. A lot of times when students measure these, they want to go from this point to this point, but this whole departure here from the isoelectric line is the Q wave, and this is an S wave. So the beginning of the QRS complex is here, and the end of the QRS complex, which is sometimes called the J point, is here. The QRS complex is usually 0.08 to 0.12 seconds. And so if it is longer than 0.12 seconds, that's going to be something happening in the ventricles or ventricular conduction system. A couple of examples of arrhythmias that would cause the QRS complex to be long would be if someone has a bundle branch block, where if you have a right bundle branch block, then the left ventricle will depolarize first, and eventually the impulse will spread cell to cell to cell to cell to cell through gap junctions to the right ventricle. And because the two ventricles are not depolarizing at one time, this may change the EKG in two ways. First, the QRS complex is longer than normal. And so again, what's the upper limit of normal for the QRS complex? 0.12 seconds. So if the QRS complex is longer than 0.12 seconds, one possibility is a bundle branch block. And another thing that changes is usually if both ventricles depolarize at one time, you have a tall, narrow spike, because both ventricles are depolarizing at one time. Okay? So let's pretend for a moment, if you could direct your attention to my image in the lower corner of your screen, if each of these two hands represents the depolarization of a ventricle, normally both ventricles depolarize together and you have a very tall spike, and it's narrow because both ventricles depolarize over a short period of time. But in a bundle branch block, because one ventricle depolarized before the other, it looks like this. It takes longer because the two ventricles are depolarizing at different times. And another difference is that in some leads you might see two R waves that are shorter than usual. Another cause of a long QRS interval is if the impulse starts in the ventricles. So when someone experiences a premature ventricular contraction, okay, so the ventricles depolarize earlier than expected, the impulse is going to be spreading cell to cell to cell to cell through gap junctions through the ventricles. And so that would be much slower than going through the ventricular conduction system. And so that results in a long QRS complex. So how can you distinguish between a bundle branch block and a PVC, a premature ventricular contraction, which is an example of an ectopic focus? Well, first, PVCs usually are going to occur isolated, so it's not going to be every beat, whereas a bundle branch block would be occurring continuously. PVCs can come in runs, so that's not always something you can count on, but if an impulse starts at the ventricles, you would not expect to see what before the QRS complex? You would see no P wave before the QRS complex because the impulse is starting in the ventricles. So, the QRS interval might be longer in a bundle branch block or in a PVC. The QT interval is again an indicator of the duration of ventricular muscle cell action potentials. It includes ventricular depolarization and ventricular repolarization. So I am going to give you a rough approximate of the QT interval, but the PR and QRS intervals are pretty much going to be within those ranges. The QT interval is the first thing I'd like you to know about is it's very heart rate dependent, okay? Such that if heart rate speeds up, QT interval gets shorter, and if heart rate slows down, the QT interval gets longer. Does that mean that the ventricular muscle cell action potential changes in duration with heart rate? Yes, that's what that means. We have to actually speed up the duration of the cardiac action potential, or it would limit our ability to increase heart rate. Some individuals have mutations in various potassium ion channels that can prolong the QT interval and increase the risk of arrhythmias. We call this long QT syndrome. And this means that with a long ventricular muscle cell action potential, it sets up a scenario where you might have part of a ventricle depolarizing before another part's done repolarizing. And this can result in fatal arrhythmias. This long QT issue is also a possibility with a variety of drugs. Recently, the drug hydroxychloroquine, which has been used in the past to treat malaria and lupus, has been suggested as a treatment for COVID-19. One of the problems with it, however, is that it prolongs the QT interval. And so that increases the risk of cardiac arrhythmias, and it's been determined to be a cause of death for a number of individuals who are given it. And finally, the RR interval is very important because it's how we're going to determine heart rate. So if you were to get a calculator out or just open it on your computer, if there's 0.8 seconds between beats, what would be the subject's heart rate? And how would we figure that out? Well, there are 60 seconds per minute, and if there's hearts beating every 0.8 seconds, you could do 60 divided by 0.8, and you would get 75 beats per minute, right? So if the RR interval was 1 second, that means the heart's beating every 1 second, their heart rate would be 60 beats per minute. And if their RR interval were 0.5 seconds, what would their heart rate be? 60 divided by 0.5 would be 120 beats per minute. And what if the RR interval were 2 seconds? That would mean the heart's beating every other second. The heart rate would be 30 beats per minute. So these intervals will be critical for understanding arrhythmias. Another thing you should understand about EKGs is where our recordings are. We would usually have an electrode on the right arm, on the left arm and left leg. Quite often with exercise placement, we might place them more centrally but representative of those areas. Also nowadays our electrodes are sticky, so you don't need a strap like this. And then you have a number of electrodes placed around the chest, our chest or precordial leads. And understanding which lead is positive and negative would help you to identify which direction the electrical activity is spreading. So limb lead 2 is in this plane relative to the heart, and usually the electrical activity is mostly spreading in this direction in the heart. And so in limb lead 2 you usually get a very upright QRS complex. AVR has a positive electrode on the right arm, kind of the opposite of limb lead 2. And so if the electrical activity is going this way away from the positive electrode in AVR, it's common for the EKG in AVR to look kind of upside down, where the P wave is upside down, the QRS complex is mostly upside down, and the T wave is mostly upside down in AVR. You'll cover that more in the lab course if you're taking that course. So why are these electrical events so important? Well, these electrical events are going to dictate all of the mechanical events of the cardiac cycle. Changes in pressure, changes in volume, which also influence things like heart sounds and flow in the aorta, are all interrelated. And so abnormal electrical activity may influence our ability to generate the enormous amount of pressure that's necessary to overcome aortic or pulmonary artery pressure and to be able to eject blood. We're going to cover this figure, Wigger's diagram, in much greater detail in a little bit.